I am Sidney Smith. I met or spoke with some of you, I think it was yesterday, welcoming you. And I'm a cardiologist, currently at the University of North Carolina, and I've worked with the World Heart Federation. I'm now the immediate past president. Previously was president of the American Heart Association. I've chaired the American College of Cardiology, American Heart Association guidelines, and most recently chaired the 6 new statements coming out of NIH on cardiovascular prevention. It's a $22 million project looking at what medications, how we can calculate risk, what about lifestyle. So my interest, even though I still am in the cardiac cath lab doing invasive procedures, I'm very interested in prevention. And one of the things that I've done with guidelines is to try to see how we can make science, to get it to the patients. And in that regard, the science that gets to the patients is either in the form of a procedure, a pill, or a diet. And with regard to pills, as patients grow older, they frequently are taking more and more pills. It's not unusual to see an older patient come into the hospital on 8 to 12 pills. One of the things that has challenged me, interested me, concerned me, has been we know that these therapies work. For instance, in coronary artery disease, we know that the use of 3 to 4 key medications, aspirin, a statin, an ACE inhibitor, or beta blocker, the use of these medicines may reduce future events by as much as 70%. It's phenomenal. It is the answer. And yet study after study after study using the current pills and therapy is showing that a minority of the patients are taking all 4 of the medications. So why is this? One of the leading reasons is it turns out that the more pills we have to take, the less likely we are to take them. The more frequently we have to take them, the less likely we are. So twice a day rather than once a day. That has led to the idea that if we could combine all of these medications into one tablet, it just might have a huge impact. Remember the 70% or so I told you. So there's several challenges in there. Along my way to medical school, I got a degree in chemical engineering. So I'm very interested in these stents and polymer coatings and so forth. I'm also interested in what happens when you try to take 3 or 4 pills and combine them into one. How do you know it's going to work? What's the interaction potentially on these medications? So the stepwise progression to saying, take this heart pill rather than 4 of them or 3 of them involves a number of key observations. The one that the combination, in fact, is active, and does it have the same benefit in reducing blood pressure, cholesterol, and so forth, the antiplatelet activity that taking the pills separately would have. You need to know that before you even get your body totally under the water, which means the next question we need to know is the outcome. Are patients more likely to take 1 pill than they are the 3 or 4 pills? And that needs to be tested in a randomized control trial. We need to know that. And then finally, the holy grail of outcomes. If we use the single pill, are patients actually going to do better than if they're told to take 3 or 4? Another very important consideration here is the population. The population. And the 2 that we deal with here are secondary prevention. These are people that have had an established event that are known to be at high risk, and that is a very we would say a low-hanging fruit situation, because in secondary prevention, there's very little argument. about the benefit. A more difficult group is in primary prevention. And so the issue there, it has to do with assessing the risk. We know what it is with heart attacks and so forth and strokes. At what point might we want to intervene, and would we try to use this pill in a primary prevention population? The majority of trials now underway are secondary prevention. And so the questions that we're going to want to hear from the two presenters will center around what medications have you decided to use in these pills and why? And do you have varying doses of each medication in the pill? Do you know that they effectively lower cholesterol, control blood pressure, and so forth, as well as if the patient had taken the pills separately? What do you know about adherence? Is it more likely that you tell them this is your heart pill? It's a nice ring to it. I'm going to take my heart pill once a day. Does that mean that they're more likely to take it every day? Than intuitively, we'd think so. And then finally, do you have any outcomes? And the people that are taking these pills, can you tell me that taking these pills versus these pills separately actually improves the outcome? Fewer heart attacks, fewer events, more alive. So it is if you think about, and cost, of course, enters into it. Cost, very important. Now, if we get out into populations where we're not going in to see doctors, we don't have all this personalized medicine, and we can get a pill into the patient's hand that is low cost, that they will take daily, we can have an impact, a big one. That's why these are so important. And Professor Yusuf, who's just come into the room, is really deeply involved in this. And he's a man that has, and you've followed his career, done many, many clinical trials. And as he moves out into the work in developing countries especially, he's been a real leader in the concept of the polypill, trying to understand how it might work. Salim, we got started. If you'd like to say a few words.
My apologies. I was held up by another meeting. Then these things tend to go on, especially if they're interesting. I think the evidence that using a handful of pills, beta blockers, ACE inhibitors, statins, and aspirin, each reducing future events by about a quarter, is absolutely incontrovertible. What's also true is that their effects are additive, which means collectively they will, if people take it, they will lower the risk by about 3/4 to 80%. Now remember, those quarter comes from trials where there was already non-adherence. So I think it's possible. But in reality, things may not work out the way you want it to, but it could work out that it's 2/3 of what we project. But 60%, 70% is huge. If you combine it with simple lifestyle modifications, smoking, fruits and vegetables, exercise, and you have 90% compliance, we have modeled this and published in the European Heart Journal, you should get a 90% risk reduction in cardiovascular disease. That is huge. Imagine a penicillin for cardiovascular disease. Cardiovascular disease is the biggest epidemic history has ever known. And yet, we are failing to implement it. The polypill is a vehicle. The polypill by itself is not enough. Now, why do people not take these drugs? I presented earlier on today and yesterday and then later today that one is cost. Even generic ACE inhibitors, statins, aspirin are unaffordable in low and middle income countries. Why do I say that? When you think of cost, you've got to think of cost as a proportion of your disposable income after shelter, after food. In the rich countries, even if there wasn't drug coverage, the cost of taking these four is only about 1% to 2% of your monthly income. In low middle income countries, it is between 40 and 60%, 40% in the urban settings and 60% in the rural settings. So when you get somebody with vascular disease, and this is work that a PhD student of mine has done, and we're about to write it up, if then you get people who have to spend 50% of their disposable income on 4 pills, that's a household's income. Remember, somebody else in the household may have other problems. There's clothes to buy, there's school fees to pay, there's transportation to do. Guess what? It's not surprising they don't take it. Now, the polypill, the first thing it will do is it will reduce the cost of these things. The retail cost in India is half the cost of each of these put together. In India, each of these things put together is about 30 rupees. The polypill is marketed at 15 rupees. So immediately you've got a halving. But if the government step in, insurance companies step in and purchase it in bulk, that 15 rupees can become 5 rupees. Imagine 5 rupees, 150 rupees for a month, $2 treatment. So now instead of being 40 to 50% of the monthly income, it becomes 5% of the monthly income without having universal health coverage and all that kind of thing. Now, if that came about, that'd be even better. So I think, and we've shown in that study that I referred to you, that the more unaffordable it is, the less likely people will use it. Second is if you have a single pill that you have to distribute, you have an easier distribution chain management. Procurement is simple. Inventory control is easier. Distribution is easier. Avoidance of waste is easier. So there are all these things. So if this becomes an essential drug, and we have to lobby to make this, the polypill, an essential drug. Antony and I tried, we didn't win, but we're going to try again. If it becomes an essential pill, medication for the control of cardiovascular disease, high-risk primary like hypertension and secondary, and get it on the formularies of every country, find mechanisms of manufacturing it inexpensively, procuring it, and that's where I was at the last meeting, and say we created a public-private partnership where a handful of companies around different parts of the world, like 1 or 2 in Africa, a few in Asia, a few in other countries, agreed to manufacture, but there was advance purchase commitments from the governments and from large insurance companies. Like Kaiser, at least people have said, we'll buy it if there's one there. It'll save us money. And even in the US, money is now becoming a big thing. And adherence is becoming a big thing. So patients stop taking it, the doctors get docked. So I think it's bloody good idea. Sorry, don't quote the B word, but it's a great idea. So the polypill is a vehicle. Don't think of it as a magic pill. It's a vehicle, but you need to tie it with a health system, a business plan. You need to tie it with the delivery of people. Now, if a patient who is stable 3 years after an MI has to go every 6 months to see a doctor and get a prescription, they lose a day's wage. They spend money on that. And then they pay the doctor in most countries. I mean, I live in Canada, Stuart there lives in the UK. We have the luxury of a universal health coverage. We don't have that in most countries. So the overhead costs of getting it is high. And in some countries like Malaysia, they'll only give you pills for 1 month. That's the way it is, 1 month. And then you got to go back. So now let us think of a scheme where instead of the patient going to the doctor, how about somebody going to the patient's home? Just like that's the way malaria control, TB control is happening in various parts of the world. And you will hear today in the hotline session, and I'll urge you to go there, a presentation by Dennis Xavier on the spread study. It's not the polypill, but it's a delivery system of using community health workers who go to the home, sit down with the people, educate them on the importance of adherence, on blood pressure, and on lifestyle. And the results are spectacular. They really are spectacular. And these are people with high school degrees with, I think, several weeks of training. So they're really low-level workers. Their salaries are, I don't know what, but if you ask me to hazard a guess, I'd say it's about 8,000 rupees a month. 8,000 rupees is, Anushka, what it would be divided by 50. I mean, more or less. What is it then? $125. Now, that is a model. So now combine that, systematic screening, adherence, pill delivered in the home step, with a low-cost pill procured by governments at no cost. Voila, we have the penicillin we want. It's a combination of the polypill and a healthcare system. So think of the polypill as part of a system. The polypill alone can't do it. So penicillin is available, or it works for rheumatic heart disease. But why aren't we controlling rheumatic heart disease? Because we don't have a system. So my plea would be, as you write your stories, talk about the story of creating health care systems at low costs involving non-physicians, using fixed dose combination pills, and it's not perfect for everybody, but it's good for the majority. And that's where the polypill comes in. And I think the starting point is secondary prevention. The next one is high-risk primary prevention. We know in hypertension we need to use drugs, and we need to use multiple drugs. And we need to control other risk factors like lipids. The Ascot study, which you published, showed that both worked. And in that study, if you lowered blood pressure and you gave statin, so you had a 50% reduction. So, and that was against usual care, which was 2 other drugs. So I can see this being a big revolution. We need your help. You're not here just to report a story. I'm going to ask you to enlist in the army. And the army is, we have to get the message out there that this polypill, along with the healthcare system's change, is going to be big time. And wouldn't you like to be part of that army and tell your grandchildren, I was part of that team that reduced cardiovascular disease by 50%? That's what I'm going to leave.
Now, if this man can't get you to take 1 pill a day, no one can. That was brilliant. Well put. And Dennis Xavier was one of the abstracts I gave you yesterday in the introduction, so you have that.
Spread is the name of the study.
It's
And
outstanding.
he's presenting in this
Yeah,
up.
it's fantastic.
Outstanding.
Gets beyond the traditional medical delivery system. So should we go on and let our 2 presenter, Dr. Selak, first of all, from Auckland, New Zealand?
What I'm going to talk about today is a trial of a polypill in New Zealand. It was designed some years ago and it's finally been completed. I'm going to go over the rationale of the study, although much of that rationale has already been covered very well by Doctors Smith and Yusuf. And I'm going to talk about the design of the trial and give you some information about the primary outcomes. As has been discussed, antiplatelets, statins and blood pressure lowering drugs are recommended for people who've already had a cardiovascular event, and that's pretty much across most countries in the world. But despite this evidence, there are large treatment gaps, even for relatively rich countries. What Professor Yusuf showed beautifully in the PURE study was that looking at 4 recommended treatments for people who've had a cardiovascular event, so that's aspirin, statin, ACE or ARB, and some other blood pressure lowering drugs. Even if you look at high income countries, only 44% of people in those countries are taking that combination of medications. And then when you look at countries of lower income, the proportion of people taking that combination is even lower again. So I think that's really the tragedy of the situation, that despite us having this evidence, we're really not putting it into practice. And there are a whole lot of reasons why this is not happening. This is the data from New Zealand from the from the University of Auckland, which looks at dispensing data, and it similarly found that if you look at people taking the combination of 3 medications, only 59% of people were taking all 3 medications. That's where the polypill fits in, and it's one strategy that may assist in addressing this treatment gap. And what I should also point out is that it's not, medication is not the only answer to addressing cardiovascular disease. We do need to address population preventive strategies. We do need to address behavioural factors, but frankly, if you've had a cardiovascular event, you need to be on these medications, and as you've seen, so many people are not actually taking those medications, so we can't ignore the issue that people who ought to be taking medication are not actually receiving them for a variety of reasons. This idea of taking medications for people who've already had a cardiovascular event has been around for a very long time, and in fact predates the Walden Law article that talked about giving everybody the polypill who was over 50. And it really is the low-hanging fruit of cardiovascular disease, and it really makes a lot of intuitive sense. It passes the grandmother test. What we've seen in the trials so far is that the short-term action is as you'd expect based on the constituents of the polypills, and we've already had 2 trials that have looked at the use of polypill-based care in people at high risk of cardiovascular disease, but most of this evidence is in secondary care. What I'm really interested in is looking at what the role is of a polypill in primary care, which is where, certainly in a country like New Zealand, where most cardiovascular disease medication management actually occurs. A team of people developed this trial that was based in primary care, and it wanted to see whether if we had access to a polypill in primary care, whether it would actually improve adherence and risk factors in people who have indications for these medications. So this trial impact was designed. We had equal recruitment of Māori and non-Māori, and people were randomised to either a polypill or to usual care, and people were followed up in the end for an average of 23 months. In New Zealand, people who've had a prior event or who have a calculated cardiovascular risk of 15% or greater over 5 years are recommended for triple therapy. So those were the people that were included in our trial, and we had relatively limited exclusion criteria. Essentially, we're wanting to apply the polypill in to see if it would assist with the adherence to the New Zealand guidelines. But obviously, if people had contraindications to any of the components, they were ineligible. There were particular medical conditions. We didn't want put patients at undue risk. And very importantly was the fact that the GPs the general practitioners made the ultimate decision as to whether patients were suitable for inclusion in the trial based on their decision that they were uncertain as to whether the balance of benefit and harms would prefer polypill or usual care. So basically there was this concept of equipoise where the clinicians were not certain whether participants were better to be managed with a polypill or with usual care. And ultimately, if the GPs felt that changing the person's medication would put the person at risk, they weren't eligible for the trial. The polypills that we used contained low-dose aspirin, simvastatin, and lisinopril, with a 4th ingredient that was either atenolol or hydrochlorothiazide. As you can see, it was a capsule. It was about the size of, in New Zealand, an augmentin tablet, so it was quite a sizable capsule, but people didn't seem to have problems swallowing it. And very importantly, because of this pragmatic design, was that we encouraged all GPs to use local guidelines. That's whether their patients were randomised to polypill or usual care. There were no restrictions on what people did with the polypill or with their other medications. So it was really testing out the real life strategy of, well, what would happen if we had a polypill available right now, if it was one of the tools in the GP's toolbox. Another really important point is that the polypill, along with other usual care medications, were prescribed by the usual general practitioner, and they were dispensed by community pharmacists. So patients actually had to receive a script from their GP and go to a pharmacy and receive their intervention as well as their usual care meds if they were randomised to the usual care arm, and they also had to pay. And we asked them to pay what they would normally pay for having a single medication. And that's because if the Polypill were to be registered in New Zealand and if it were to be funded by our funding body, then that is probably the likely scenario. So if essentially they would be, the dispensing fees would be less than if they were having the medication separately, but they still had to pay something to receive their medication. We initiated recruitment in July 2010, and it took us some time to recruit our patients. In the end, we randomised 513 patients from 91 GPs and 54 practices across the Upper North Island, and we had a very good follow-up rate and achieved sort of over 95% primary outcome data. The average age of our participants was around 60. As I mentioned, half were Māori. About 45% had a history of cardiovascular disease and other people had no such history. The baseline level of adherence to antiplatelet, statin and 2 or more blood pressure lowering agents was around 43-44%. Now, our primary outcomes, we had 3 primary outcomes. One was the use of antiplatelet, statin and 2 or more blood pressure lowering agents. The other was a change in systolic blood pressure. And the third was a change in LDL cholesterol at 12 months. As you'll see, what we found was there was a significant improvement in adherence to recommended medication. We found that the reduction in systolic blood pressure did not reach statistical significance, and we also did not see a statistical difference in the change in LDL cholesterol over the 12-month period. The main reason for the apparent discrepancy between self-reported adherence and risk factor outcomes is when you drill down to the differences in adherence between the individual components of the Polypill. Firstly, what we were looking at was antiplatelet adherence, and we saw that if you looked at individual modalities, that people on the Polypill, 93% of those were taking an antiplatelet agent versus 83% in the usual care arm. So there was a 10% absolute difference in the use of an antiplatelet agent. But we didn't actually measure platelet function. That wasn't one of our outcome measures. In terms of the statins, we saw a 5% absolute difference in the use of a statin between the Polypill arm and the usual care arm. So there wouldn't actually be, we wouldn't expect to see much of a difference in LDL based on that absolute difference in use of a statin. And thirdly, when you look at the differences in blood pressure lowering agents, although we found that 89% in the Polypill arm were taking 2 or more blood pressure lowering agents compared with 59% in the usual care arm, when you looked at the proportion of people taking any blood pressure lowering drug, the absolute difference between those two proportions is only 5%. And so therefore, the actual expected difference in systolic blood pressure is not very great and is kind of consistent with what we actually found in our trial. The trial was, I think, very good in terms of its pragmatic design, in terms of the fact that it was embedded in primary care and also the equal recruitment of Māori and non-Māori participants. However, we did have issues with the power in our trial, and that was primarily because we actually got better than national usual care. So one of the first slides I showed you was that the proportion of people in New Zealand who were taking an antiplatelet, a statin and blood pressure lowering drugs is about 59%. This is among people who've had a cardiovascular event. But actually in our trial, when you just look at the people with a history of cardiovascular disease, 82% of people were taking that combination. So actually the participants in our trial were reflective of a very high standard of care. So in conclusion, the results of this trial, in combination with the short-term risk factor trials as well as the other trials that have already been published, indicate that there is potentially a role for the Polypill in the management of cardiovascular disease. However, there are some information gaps that need to be addressed. One of them is cost, and we need to factor in not just the cost of providing the polypill, but comparing the costs of polypill-based care with usual care. The second issue is around actually implementing such a strategy, and Professor Yusuf has talked a lot about implementation strategies and health system approaches, especially in lower and middle-income countries, and that's very important. Thirdly, though, what we do need to do is to look at the combination of our trial with the other trials that have already been completed. So I think at this point I'd like to hand over to Ruth, who's going to be talking about the meta-analysis of the trials. These are our funders and acknowledgement.
Okay.
And the adherence again to the single pill versus the multiple pill was, how to compare?
The way that we measured it was self-reported adherence. So we asked participants what they were taking. If they were taking something that was an antiplatelet and a blood pressure lowering drugs, or two or more blood pressure lowering drugs, and a statin, then we see that they were adherent at the time point that we were interested in.
What I'm after is how much, given the limitations of self-reporting, but let's say that that's accurate, how much difference did you see in taking a polypill? Not in terms of the surrogate measures, but they were taking a polypill, was it 89% of the time, whereas they took all three pills, what percent?
I don't know. We didn't measure that. What we asked people simply was at the follow-up points that we were interested in. It was a dichotomous outcome, so we were asking them, were they taking that medication, yes or no?
Okay, so we don't know how much taking the single pill actually might improve on getting the triple therapies in on a daily basis.
Well, we do know compared to, we measured the adherence in the same way in the polypill arm and the usual care arm. So based on that measure, there was a difference.
See, what happens when you have a trial like this, has happened in the Sri Lanka trial, is the control group, the physicians start to increase the medications they use, because they're now more aware they should use it. Like in Sri Lanka, if you look at data in the community, very few people get statins and blood pressure lowering or more than one drug if they're hypertensive. But when they got randomized with the trial, practically everybody got a statin and practically everybody got multiple drugs. It's that Hawthorne effect.
Absolutely.
And I think you had some of that happening here too.
Yeah.
Because as you said, the use in the control group was much higher than your national average.
Yeah.
So that's a challenge in studies like this.
It's difficult to get that out in terms of trial design. Are there questions?
Could I just, so go back to that question, would it be fair to say that the baseline adherence case was 43%, and then in the trial it was 82%? Could you use that as a comparator?
Actually, the data that you're quoting, the baseline, that's the combination of people with a history of cardiovascular disease and the history of people without cardiovascular disease. So what we will need to do, and what will be done subsequently, is dividing out the results based on whether they've had a prior cardiovascular event or whether or not they haven't. Because, I mean, not surprisingly, if you've had a cardiovascular event, your chance of being prescribed the medications is greater than if you haven't. Although I think, as I mentioned, the national data shows that the adherence to the triple therapy in people who've had a cardiovascular event was about 59% compared with over 80% in the trial, and that was the baseline data.
We should go on because then we can take questions all together. Ruth, would you like to present?
Sure.
Okay, the next will be Dr. Ruth Webster.
Now, my apologies, I have no slides, but I will have slides this afternoon. Hopefully I will quote everything you need to know in my talk. I'm very thankful to be going last because I can benefit from what everyone else has said. And can I just say, as to regards to the background and the rationale of what I'm about to say, ditto, ditto. So, and onwards. So, as mentioned, the IMPACT trial was part of a larger collaboration of clinical trials, which was entitled the SPACE collaboration. And the SPACE stands for Single Pill to Avert Cardiovascular Events. Modesty was our second word. The Space Collaboration is a group of academic investigators at a global level who are all committed to conducting polypill trials, particularly in participants for whom the component medications were already indicated. So the secondary prevention, patients who have already had a heart attack or stroke, and also the high-risk primary prevention, patients for whom these medications are already indicated to be taken. The investigators all conducted independent clinical trials. It was important to show effect in their local situation. The trials were adapted for, they had their protocols were designed to be deliberately similar, but they were also adapted for local requirements or local clinical situations. They were all funded by local funding agencies, such as the NH and MRC in Australia, the MRC in New Zealand, and the European Commission funded the individual trials, and they were all designed with the eventual aim of combining all the data together to create one large data set that we could then analyse. The reason for combining data into one large data set, and what else can we know apart from what the individual trials are reporting, is it does allow us to achieve greater precision around the estimates of what the effect of the polypill is. It does allow extra analyses to be conducted that aren't easily done on a smaller data set, and it also allows us to look at subgroups of patients, such as if you're male or female, or if you've got diabetes or not, if you've got red hair in one leg, we could look at that if we collected that data. It just allows us a little bit more information to come out of the data set. So all of the patients in the 3 trials that I'm going to be talking about were at the highest risk of having heart attacks or strokes. They either had previously had one or they're at high risk, greater than or equal to 15% calculated risk over the next 5 years. The polypill in these trials was, as outlined by Vanessa, contained aspirin, a cholesterol-lowering medication, simvastatin, and blood pressure-lowering medications, all of which have individually, as mentioned by Professor Yusuf, been shown to independently prevent cardiovascular events or heart attacks and strokes. And again, as has been mentioned, all these patients were supposed to be taking these medications. So the polypill was compared to usual care, which was simply whatever the doctor would usually do to manage cardiovascular risk in these patients. As again we've heard, we do tend to get better than usual care in clinical trials, although the trials were designed to try and minimise that effect. We genuinely wanted to see what would happen if you put a polypill out into the real world. So the aim of all these trials was the same, to see if combining recommended proven medications into one pill could help people take these medications more reliably by reducing the complexity of the medication regime and also reducing cost. 3 trials were included: the IMPACT trial from New Zealand, the Canyini Gap trial in Australia, and the Umpire trial, which was conducted in Europe and India. When combined all together, we had 3,140 patients worth of data to look at. And the average patient, I guess, in that meta-analysis, or the baseline characteristics, if you will, they were on average 63 years old, 25% were female. They were overweight, with just under 30% being current smokers. Their blood pressure was about 140 on 80. 65% had a history of coronary heart disease already, and 14% had a history of stroke. Their mean total cholesterol was 4, HDL just over 1, about 35% had diabetes, and the use of the 2 polypills was about evenly split, about 50-50. So when we combined all of the data together and analysed it, we had the same primary outcomes as each of the individual trials, which was looking at adherence to an antiplatelet agent, a statin, and combination blood pressure lowering therapy. That was one of our primary outcomes. The other 2 primary outcomes were systolic blood pressure and also LDL cholesterol. So when we combined them all together, we found that approximately 40% more people in the polypill group were taking the recommended combination of medication at 12 months. Our endpoint was 12 months, compared to the usual care group. And the absolute percentages were 78% at 12 months in the polypill group were taking combination therapies versus 54% in the usual care group. We also found a drop in blood pressure, systolic blood pressure of 2.8 millimetres of mercury, and a drop in cholesterol of 0.1 millimoles per litre. When we split the data into subgroups, such as male versus female, older versus younger, we found that the increase in adherence, and I'll primarily talk about adherence just for the sake of time, was seen across all of the subgroups. There was a consistent effect across all of the groups that we looked at. Some groups had more effect than others, and I'll discuss just a couple of those. So one of the significant differences in effect we found was that New Zealand had the best improvement in adherence. So if you're New Zealander, the Polypill is the drug for you. We did find improvements across all the other countries as well. I'd like to stress that as well. In particular, and this is one of the biggest findings we had, we found that patients who weren't taking the medications at the start of the study were over 4 times more likely to be taking their medications after 12 months than those who were taking their medications at the start. So if patients were taking these medications when they started the study, there was still a small percentage improvement, a significant improvement. They got benefit from it. But if they weren't taking the recommended medications as they should have been, we found a huge improvement in the number of patients who were taking them at the end of the study. And of course, that is the population which is our target population, particularly with the polypill. If you're happy to take all 4 individual pills and you are taking them, that's fine. You don't have to take a polypill. But if you're struggling to take all the medications, or if you don't have access to them, or for all the other things that Professor Yusuf has been talking about, then this could be a huge help in bridging that evidence-practice gap. We did look at cardiovascular events, which was one of the aims of having a large group of patients, but unfortunately we were ultimately underpowered to do that, and we haven't been able to make any conclusions about actual hard cardiovascular events like measuring strokes and heart attacks as such. So what does this mean in practice? Overall, we believe that using a polypill can help people to take their medications more reliably. And this is, of course, of particular relevance, as all the component medications in the polypill have been proven to reduce cardiovascular events or heart attacks and strokes. But if you don't take those medications, you don't get the benefit. The polypill was especially effective for patients who weren't taking all the recommended medications at the start of the study. And there's, of course, millions of people in that situation across the world. The polypill also improved adherence across all subgroups of the population that we looked at. And that means widespread applicability of the polypill. From the stockbroker in London to the office worker in New Delhi to the housewife in Sydney or Auckland, anyone can benefit from taking a polypill and improve their adherence to these recommended medications. So where to from here? First of all, we have more analysis to do. This is very much cutting edge, up to the minute data. We are still slicing and dicing our data and looking at other outcomes of interest. But we also do need to get the polypill onto the market. It's all very well to show that it works, but the next step is obviously to make it available. And there are some polypills available in the world. There are some available in Asia. I heard this morning apparently Tanzania has also got a polypill now, and some Latin American countries. In terms of how long it might take to get a polypill on the market, I guess here in Australia and elsewhere, these things take time. To get a drug through the TGA, my understanding is 18 months to 2 years. But we would hope that maybe within a couple of years we might see a polypill on the market here in Australia and in other big markets such as the US and the UK as well. Secondly, these trials have shown a proof of concept for this idea of combining medication together into a simple pill. Other options now to explore incorporating other medications into similar polypills across different disease categories. For example, patients with diabetes, another group that's got a large patient population worldwide that could benefit from combining lots of drugs into one pill. And finally, as Professor Yusuf has mentioned, this is not the one pill wonder. This is one piece of the puzzle in preventing cardiovascular events globally. So I'll leave it there. Thank you. I guess we'll take questions.
Questions?
I have a question for Dr. Webster. I just wanted to check. It was a 2.8. Oh, sorry. Thank you. It was a 2.8 milligrams of mercury reduction in systolic, and was it a 0.1 millimole per liter?
Yes, 0.1
Okay.
in LDL cholesterol.
Okay.
Yes, that's correct.
So my follow-up then to yourself and the panelists, in these patients that are relatively high risk for cardiovascular disease, 15% over 5 years, some with established disease, are these reductions large enough to actually be protective against recurrent events, or is there a risk that there might be undertreated? I know that's one of the criticisms of the polypill, is that it could lead to undertreatment.
I think from our perspective, it is a modest increase, there's no doubt about that. What has to be kept in mind is that our usual care group was being treated as well. So we're not seeing a placebo, compared to placebo effect here, where you might expect the 10 to 15 millimetres of mercury improvement in blood pressure or large improvements in cholesterol. It wasn't compared to a treated group. I think what the blood pressure and the cholesterol do signify is that we showed a genuine improvement in adherence. And you could argue that they're undertreated, but our Polypill group were, I think, unarguably better treated than the usual care group, and that's what we saw. The other thing to keep in mind is that at a global level, when we're talking about hundreds of millions of patients who might potentially benefit from these therapies, even a small improvement in blood pressure of just under 3 millimetres of mercury has the potential to avert a large number of cardiovascular events.
Ruth, did you look at the group that started off with no drugs or many drugs? Because that'll give you a better idea of the truer effect.
Sure. We haven't done no drugs at the moment. We've done either
say
taking
less than
everything or, less than
Less
ideal.
than one or less.
Yeah, we haven't done that sort of specific yet, but that will give us a better idea. We
Because
haven't
the
got that deep
concept
yet.
of the polypill is that you're able to get across more drugs.
Yeah.
So you're right. If they're already taking all of them, then you don't really expect a whole lot of a difference.
That's correct.
That might be. I just a rough back of the envelope calculations. Even these tiny differences that Ruth reported should lead to about a 9% incremental relative risk reduction in cardiovascular disease. And that 9. No, that's not huge, but it's important. So this is, you treat people well, and versus you now add a polypill. So there is a benefit. That's not huge. But the problem is, as we've seen from other data, most people don't get all these drugs.
And I think that perhaps the extension of that is that at baseline, and I can't remember. I can't remember exactly what percentage at baseline were already treated, but it's about 60% were already treated at baseline. So we're talking about high-income countries, sort of averages there. If this was solely lower middle-income countries and we started from a baseline of 10%, you'd probably see better improvements.
Jason Gale from Web News. Just in the local perspective, this would have a huge impact on the pharmaceutical benefit scheme if the government was only paying for one drug as opposed to multiple.
Absolutely.
And it's not really paying, it's the distribution and storage costs. So imagine a room like this full of 4 or 5 drugs, but now it's only one drug. So the room is now less.
Right.
Your inventory control is less. Your pharmacists can deal with it. Your stock out problems are less. Your distribution system is easier. So it's not just that cost of drug. There's so many other things that go with it that we haven't thought about.
Yeah.
As a follow-up question, James Tullis from Heart Foundation. Could you give us an idea of cost, if you know, for an average Australian patient in the Australian setting, what is the average daily or monthly cost for the 4 usual drugs, as opposed to the potential cost for a polypill, which Professor Yusuf said?
I don't know the costs in
maybe Ruth would
Australia, but I can tell you whatever cost is in Canada, it's got to be 50% higher here. Your cost of living is ridiculously high. So,
Yep.
I mean, I can't even buy a sandwich here.
They should pay you more.
That's right. I think certainly from the local context, if you're just looking at it from a patient perspective, I guess the critical start, where you start from with a patient is the co-payment that they pay. I saw a statistic somewhere that 80% of statins are purchased by pensioners or low-income, concession card holders. So we're pretty much dealing with the lower end of the economic spectrum. And they pay a co-payment of, I can't remember what it is, something just below $6 per drug at the moment. So on just a very simple level, if you're cutting down from 4 to 1, you're reducing your cost by 75%, just to the individual who's paying for their drugs. In relation to the cost of the PBS, which of course pays a lot more than the co-payment, and this is where we've just had there's been a lot of press recently about how the government is getting ripped off, for want of a better term, about drug costs. Certainly there's the potential to be significant savings, and Anushka just provided an excellent figure in the last session that in the Canyini Gap trial in Australia, which was 623 patients with a median follow-up of about 18 months, the estimate was a savings of about $500,000 to the PBS scheme, just by doing the trial, let alone extrapolating that further. So there are potentially huge costs. How big the cost will be, how long's a piece of string, It's hard to know how much this pill will cost when it gets on the market, but the commitment by the people involved in getting these pills onto the market is to make it affordable and much less than currently.
I can
it
give you
costs.
the example of India, where it's now been on the market for the last 3-4 years. In India, each of the components together work out to 30 rupees, 30, which is approximately $0.50. The putting into the polypill at the same dose is half, 15. This is retail cost. The company has agreed that if there is a bulk purchaser, like a government or an insurance company, that 15 rupees will come down to 5 rupees. Now remember, they're still making a profit, and that's perfectly fine. So 5 rupees times 30 is 150 rupees, which is $3 a month. And let's say you pay 10 times that, or 5 times that here. $15 for 4 life-saving drugs is pretty good, so it'll be, and it'll depend on the negotiating power. If the government says we're going to buy it as a mass procurement, they've got huge negotiating power, and they'll be able to negotiate good prices. Like in India, the state governments negotiate incredibly low prices compared to what you buy it in the pharmacies. So price will float, the evidence won't,
Michael Woodhead from Australian Doctor. Could you explain what's the situation around if somebody's already on 1 or 2 of the treatments, say if somebody's already taken, say, Lipitor, what happens then? How do you introduce the polypill in that situation? And would there be any resistance from a cardiologist who doesn't want their patient coming off a high dose or high potency drug for a lower one?
I think you've covered about 3 questions in one there. Firstly, cardiologists are quite hard to convince about the polypill as a general rule, is my understanding, partly because of the perceived lack of ability to tailor medications to the individual, which may include, say, going from Lipitor down to statin, perceived down to a statin, simvastatin. I guess the answer to that is we have picked certain drugs to go into these polypills in the trials for pragmatic, practical reasons. When they eventually get onto the market, it may not be the same components. I would be very surprised if we didn't see an atorvastatin polypill on the market when they actually reach the market, which removes that issue. There will also be a range of dose ranges available. There may not be the breadth of every possible dose that you could imagine, but there will be some flexibility for tailoring of treatment. In terms of how to get a patient from say one drug onto the many, that is obviously something that will require education and guidelines around what are the principles behind that. In practice, there are issues around what will be the the terms of marketing approval, what you're allowed to do. Is this a drug that you can only use if you've been stabilised on the individual components individually? That's obviously not ideal. In reality, when patients leave hospital after a heart attack, they're mostly put on these drugs straight up anyway. But it's obviously a discussion to be had.
I think the dose issue, we work with a different polypill. That comes now in 2 doses, a low dose and a full dose. And we're doing a big trial on mortality morbidity called TIPS-3 that starts with a low dose, and if it's tolerated, it goes up to the fuller dose. And then that also has a variation where you can drop the aspirin or drop the ACE depending on side effects. So all that is possible. Yeah. I think, but these are wrinkles. The main thing is the big dial question, is the polypill itself. And the idea that physicians lose flexibility is inaccurate. I think if you have a low dose polypill, you can always give 2. If you want to. And if they're given at the same time of the day, then, it's like taking 1 pill. Many of us do take pills. I take, and if you put in a little box, you take whatever you want to take.
So we've taken care of that in the United States. The aspirin dose is the aspirin dose. Statins is a dose-related recommendation now based on the evidence that's available. So that leaves us with blood pressure. with blood pressure, there's an interesting discussion if you start on a single medication, whether you should max that medication or add a second medication. Right now, the evidence is uncertain that way, but there are a number of trials that suggest you're better off adding a second medication to a moderate dose of the first. That
And
means
side effects are less.
yeah, the side effects are less. That means you take your Polypill, and if the blood pressure is not exactly where you want it, you add another pill potentially to do that, or choose the Polypill on the rack that has a higher dose. So I would agree with Professor Yusuf that these are considerations, but they're not ones that I think are going to be a major roadblock.
I have a question about the diabetes aspect. What is the level of interest in adding something like metformin to a polypill?
I'm sorry.
I'm interested in the diabetes aspect and the level of interest in adding something like metformin to a polypill.
The level of interest is at two levels. One is obviously the academic level, which is high. At the commercial level, it's non-existent at the moment. And the reason is we're struggling just to get one polypill through all the steps. If we get it through, which I believe will, Anthony's working very hard, we are working very hard, and we get it through, then that'll open the door to future polypills. Now remember, some of the future polypills may not be with the generics. Okay. Now I have to tell you, we've tried, you have, and I have tried to get Big Pharma interested. It's been very difficult. And they've been pretty open in their reasons. But one of the things is that physicians are reluctant to use combination therapy. They said they've had combination therapies like the X-Forge from Novartis. It's not selling at all. 3 blood pressure lowering agents, you'd say that's marvelous. It's not selling. The Pfizer combination of ACE plus amlodipine plus statin, what is it called? It's marketed in many countries. It's expensive, but it's not selling. So I think there is the biggest barrier to combination therapy are physicians. And the reason is we've been brought up, including me, in our pharmacology days, that you've got to be the purist, give one drug at a time, titrate it, know what it does, effectiveness and side effects. And that mindset is deep in our genes. And that is going to take a while to cleanse the genes. So I think that's going to be the thing. Now in other areas, for instance, chemotherapy, cancer doctors accept multiple therapy, TB, multiple therapy, HIV, multiple therapy. But we use that as an argument in a review article that both Anthony and I wrote. And one of the reviewers had problems with that analogy. There they said, you're giving that to sick people who've got a life-threatening disease. You're giving it to relatively and so there's going to be a big evolution there. But at every meeting I go, I ask the audience, how many of you will use it in secondary prevention? If there is, how many will use it in high-risk primary? And how many of you will put into the tap water like was suggested by Wald? And the response we got today is identical to what I got from all over the world. 90% of physicians will use it in secondary prevention if it's there. About 75% will use it in high-risk primary prevention, and practically nobody will use it just based on the age criterion, which is proposed by Walden Law. So I think let's win on those one or two things, then we can. I think we should bring this to a wrap. I wanted to congratulate both our young, talented speakers. Thank you. And Sid Smith, thank you. And thank you for coming. And my apologies for being late. I got caught into trying to develop a public-private partnership that might solve some of the problems here. Whether it will work, I don't know. But thank you.